Hello, dear doctors. Uh, Today we are going to talk about amenorrhea. Before starting, I'm asking you to subscribe uh, for more stimulation of our mood and for more making video. So let's talk about the topic. Secondary amenorrhea. This type of amenorrhea the patient had before menstrual cycle, but now stop it. There is few causes. So in a secondary amenorrhea, the causes can be um, hypogonadotropic, it means hypothalamic or pituitary dysfunction, or hypergonadotropic, ovarian follicular failure, or eogonadotropic. It can be pregnancy and ovulation, uterine or outflow tract pathology. Okay, in the pregnancy, beta HCG it's increasing. If I'm not making a mistake, it should be more than 5,000 in the pregnant, and if less, the test is negative. So the next one is anovulation. So if no corpus luteum, no progesterone withdrawal, bleeding, and therefore an ovulation is associated with unopposed estrogen stimulation of the endometrium. Okay, but as endometrial hyperplasia can be developed when there is no corpus luteum. Irregular and predicted bleeding will be occurred, and the cause of an ovulation are multiple, including polycystic ovarian syndrome, hypothyroidism, pituitary adenoma, elevated prolactin, and some kind of medications like antidepressant. So here we have estrogen deficiency. Without estrogen, endometrium will be atrophied. With no proliferative change taking place, the cause of hypoestrogenic states are multiple, including the absence of the functional ovarian follicle or hypothalamic pituitary dysfunction. Okay, and outflow of the tract obstruction. So one of the other causes of the amenorrhea, it can be outflow tract obstruction. Even with adequate estrogen, it can be happening, and stimulation and progesterone withdrawal, menstrual flow will not occur. If the endometrium cavity is obliterated or stenosed. Okay, let's go for the next. The management, how you are managing the secondary amenorrhea. First of all, we are doing pregnancy test. If it's more than 5,000 units, it means pregnancy. If less, it's negative. Cytotropin level, we are testing it, and if it's low, the patient have hypothyroidism, then you have to think about that. The cause is hypothyroidism. And the next one is prolactin. If the prolactin level is elevated, maybe it's medication, maybe tumor, or maybe idiopathic. So in the tumor, in a MRI and CT scan, we can find the pituitary adenoma. And if it is less than 1 centimeter, you are using bromocriptine for reducing the tumor and for reducing the prolactin. So if you reduce the prolactin, you will reduce the adenoma also. So bromocriptine is dopamine 2 receptor agonist. So if more than 1 centimeter, you need surgical procedure. For idiopathic also, we are using bromocriptine, the same treatment. Okay, we have two tests which are so important for differential diagnosis. So if pregnancy test, TSH and prolactin are in the normal range, so we are going to give one single shot of the progesterone or 7 days of oral progesterone acetate. And if it was positive, withdrawal of the bleeding, diagnostic of an ovulation. And we are going to manage it with cyclic MPA, okay, required to prevent endometrial hyperplasia. And if the patient wants to be pregnant, clomiphene we are using. It's helping the patient to be pregnant. Now we are going for negative. If the test was negative, absence of the bleeding, inadequate estrogen premium of the endometrium, or outflow tract obstruction. So we are going for the next test, which is called estrogen progesterone challenge test. If the PCT is negative, administer 21 days of oral estrogen followed by 7 days of the MPA. And if the test was positive, withdrawal of bleeding, the diagnosis of inadequate of estrogen will be appeared. So if elevated FSH, there's ovarian failure, and we are searching for some chromosomal changes. So this one, Y chromosome mosaicism, this one is happening in male elderly, and it's a kind of malignancy sign. And the next is Savage syndrome, or resistant ovary syndrome, is a condition in which follicles are seen in the ovary by sonography, though they do not respond to the gonadotropin. Low FSH suggests hypothalamic pituitary insufficiency. So we are doing CNS imaging. So maybe it is MRI or CT scan for all outing of the brain tumor. Okay, positive ECT will need estrogen replacement therapy. Why? Because it can be the cause of osteoporosis, and it's helping in estrogen deficiency morbidity. It's too important. So the hormone therapy is really important in the patient. And if it was negative, outflow tract obstruction or endometrial scarring, as like Asherman syndrome, any kind of the scar or adhesion happening. So this one also is important because after pregnancy, like complicated pregnancy and doing some cesarean section, uh, this one can happen. And we have to look at the history of the patient very well. So have a nice day, guys, and Happy New Year.